Most of my previous blog posts are related to medical emergencies that occur at a dental clinic. Now, an important step in managing such medical emergencies is placing an IV cannula so that we can administer drug directly into the bloodstream. This is one of the reasons I've been getting multiple requests to make a video on how to place a IV cannula. So today this is exactly what I'm going to talk about. Hello everyone, I am Dr. Zibran Khan, oral and maxillofacial surgeon. So what is an IV cannula? Now, IV cannula is just a flexible tube which is inserted into the vein so that it doesn't damage the vein as it is flexible, and using this flexible tube you can administer drug directly into the blood. Now, why do we need to administer IV drugs? First of all, they are fast in action. Let us first compare it with oral route of administration of drugs. When you administer a drug orally, it has to get absorbed from the GIT, then undergo first pass metabolism, and then it is added to the bloodstream. So it takes a lot of time from oral intake of the drug to absorption into the blood. So for example, amoxicillin, it takes around 1 to 2 hours for it to reach a peak plasma concentration level. Whereas in IV, the moment you administer drug into the IV, it has reached its peak plasma concentration because you've added it directly into the plasma, into the blood. Then it is easy to monitor. Let us first talk about oral administration. Now, when you administer a drug orally, drug has to be absorbed from the GIT, then it has to undergo first pass metabolism, then it is absorbed into the blood. So many of the time what happens is a major chunk is not absorbed in the GIT, it is directly wasted by defecation, then it has to undergo first pass metabolism. There also quite a good amount of drug molecules are wasted, and then once they are absorbed into the blood, a major portion is excreted directly out in the urine unused. So a major chunk is wasted out, and just a small portion of the drug given orally reaches the site of action where it is desired. Whereas IV administration, the moment we give IV, it is there in the blood. The amount of drug molecule that you administer in the blood is the amount of molecule that reach the peak plasma concentration. So you know exactly how much drug is going into the blood because that is the amount you are administering directly into the blood. Second point is that it is easy to terminate. Again, the example of oral route, once the patient consumes the drug, be it a tablet, be it a capsule, it has to be absorbed, undergo first pass metabolism, then added to the blood. So if you have given a drug almost an hour back, it is still being absorbed even after 1 hour. So the termination is not instantaneous. Okay, whereas in IV, the moment you stop administering drug into the IV route, that is exactly the moment where the drug molecules are stopped being added to the bloodstream. So it is easy to terminate. Then it is useful in GI disease, as we talked about the drugs in the oral route. When the patient have a GI disorder, gastrointestinal disorder, they're not able to absorb the drug from the GI to the blood. So in such patients, IV drugs are very helpful. Let us talk about the parts of the cannula. So this is a cannula, what you can see, that comes in a packet. It has different parts that we'll be talking about. So first of all, we have the stylet, metallic stylet. Now this metallic stylet is a hollow tube and it has a bevel. You can see the cut portion. This metallic stylet has a hollow bevel. Now this metallic bevel acts as a guide to this flexible tube. You can see flexible IV cannula is not reaching the tip. Okay, so this acts as a guide while inserting the cannula inside the vein. Once we have reached inside the vein, this is a hollow tube. So if we are inside the vein, blood goes into this hollow tip and it comes out through this chamber here. We'll talk about this later. So we have metallic stylet, then we have the flexible cannula. In this you can see that the tip is a little narrower as compared to the body of the cannula. The reason for this we'll talk about later. You can see it is flexible, the cannula. Then we have the wings of the cannula over here. These wings are used to fix the cannula to the surrounding skin so it doesn't move. Then we have the injection port. Now, ideally, we give IV drugs, IV fluid through this port. If during the IV fluid administration, we want to inject another drug, what we can do is we can use this vertical port to administer the drug. Now, this port has a protective mechanism which prevents the backflow of the drug. It just pushes the drug directly in towards the vein. Then we have the stylet grip. It is used to support the stylet while inserting the cannula into the vein. Once we have inserted the cannula, this stylet grip is used to pull back the stylet out of the vein so that only the cannula is present inside the vein. Then we have the flashback chamber. Now you can see, as I've told you earlier, this metallic stylet is a hollow tube, and this ends in this flashback chamber. You can see the stylet ending over in the flashback chamber. So when this stylet is inserted into the vein, what happens is the blood goes into this tube, this stylet, and it comes out into this flashback chamber. And this is how we know that our stylet is inside the vein. Then we have the locking cap. This locking cap is used to just block the open end of the cannula while it is not being used. If we leave this port open, this end of the cannula, if we leave it open, the blood is going to come out. Okay, we don't want that. Okay, that is the reason we use this locking cap to close this open end of the cannula. Now we go back to the flashback chamber. As I've told you earlier, this is our stylet is a hollow tube. So when we insert it into the vein, the blood goes into the stylet and it comes out into the flashback chamber. This is how we establish that we are inside the vein. While placing the IV cannula, we see two flashbacks of blood. Flashbacks of blood means that we see blood rushing out of the vein into the cannula. That is the flashback. So one is that when we see the blood coming into the flashback chamber. Second is when we see it inside the cannula. So we've talked about the first flashback that is seen over here in the flashback chamber. Then the second flashback we see is when the blood is pushed between the walls of the stylet and the IV cannula. We'll talk about this now. Now you can see the tip of the cannula is slightly narrower as compared to the body of the cannula. Now this narrow tip forms a watertight seal around the stylet. So when this stylet is pulled back, the seal is broken and hence the blood is being pushed between the walls of the stylet and the cannula. So you can see the black bars, they represent the diameter of the cannula, the narrower tip and the wider body, and then these are being placed together so that you can compare the sizes. You can see there's a marked difference between the diameter of the cannula tip and the body. And when the stylet is pulled back, that watertight seal is broken and the blood is being pushed inside. Hence we see a second flashback inside the cannula. I'll show you another video on this. Now in this you can see the cannula is being pushed inside the vein. You'll see one flashback in the flashback chamber, another one when the stylet is pulled back, and you see the flashback in the cannula. I'll play the video now. Now the cannula is being pushed inside, so the blood is being seen in the flashback chamber. Okay, so they know that they are inside the vein. Now they are going to pull back the stylet and you can see the blood coming in here. I'll repeat it. You can see the flashback chamber. Then once the stylet is pulled back, you can see the second flashback in the cannula. So we see two flashbacks while placing the IV cannula. One is in the flashback chamber, second in the IV cannula. Okay, I'll show you another video where it is clearer. Again, they are pushing the stylet inside the vein and you can see the blood coming in the flashback chamber. And then once the stylet is pulled back, you can see the blood coming in the IV cannula. So there are two flashbacks, one in the flashback chamber, second in the IV cannula when the stylet is pulled back and the watertight seal is broken. Now what are the different sizes of the cannula? Now any pointed object, be it a wire or a needle, the sizes are measured in gauge. So 18 gauge is 1 mm, and as the number of gauge reduces, the diameter increases. You can see 10 gauge is 2.588 millimeter, 14 gauge is 1.628 millimeter, 18 gauge is 1.024 mm, so on. So same is with the sizes of the cannula. You can see 14 gauge cannula, 16 gauge cannula, 18, 20, 22, 24 gauges. 24 is the smallest of these and 14 is the largest. 24 is used for pedo patient, young patients, infants, whereas 22 and 20 gauge needles are the most used in the adults, whereas 16 gauge, 14 gauge cannula are used when you need to do a rapid infusion of the IV fluids. Using the 14 gauge cannula, you can infuse approximately 1 liter in 2 minutes into the blood. Now, factors that affects the site of cannula placement. First is you should always go for veins in the arms as compared to the legs. In arm, always go for non-dominant arm and avoid the foot region, as we talked about earlier. Avoid leg, and that includes the foot region. And when you go for arm veins, try to go for non-dominant arm, because the patient is going to work with their dominant arm, be it eating, be it lifting objects, anything. Dominant arm should be avoided. Of course, they can be used. Of course, the veins in the leg can be used if you are not able to achieve a proper IV access in the arm. Then avoid joints. While the movement in the joint region, there will be pressure over the vein because of the cannula. If you place it over the wrist region, even though the cannula is flexible, it is still going to apply pressure over the inner walls of the vein while getting bent. So if we apply pressure over any soft tissue over a longer duration, that leads to inflammation and pain, and that pain sensation is not very desirable to the patient. So avoid joints. Then condition of the vein. Suppose there's already inflammation and infection in the region, be it the vein or the surrounding tissue. So you are going to avoid such areas. Another thing in the condition of the vein is that you cannot place IV cannula in a vein that has a tortuous path. You always place a IV cannula in a vein that is at least straight for the length of the IV cannula. So you can see there are multiple veins seen in this arm. So you cannot place IV cannula in this vein because it is not straight, it is tortuous. Okay, if you place the cannula here, it might push out through the vein. So this is not desirable. You can place IV cannula in this vein. You can see it is straight for the length of the cannula, and this vein also, because it will also be straight for the length of the cannula. So whenever you insert the cannula, always place the cannula over the vein and check whether the vein is straight for the length of the cannula. Now we come to the steps in placing the IV cannula. First, we have to inflate the vein. In a normal patient, the veins are not that clearly evident. We'll have to do something to inflate the vein to make them pop out. Second is swab the surgical spirit. Swab the area with the surgical spirit. Of course, we are creating a puncture point in the skin. We are creating a opening for the microorganisms to enter the body. So we have to disinfect the area where we are creating the puncture point. Then we insert the cannula and then we release the tourniquet. We check for the patency of the placed IV cannula, whether it is inside the vein or not. Then we fix the cannula using the surgical tape or Dynaplast. The first step in inflating the vein is we place a tourniquet. Tourniquet, what it does is it applies the pressure over the veins so that it blocks the backflow of the veins. So the blood is blocked inside the veins, and the tourniquet should not be so tight that it blocks the arterial blood flow. So when the arterial flow is open and the venous backflow is blocked, so what happens is blood is coming in but it is not going out. Hence it is going to force the veins to bulge out. It will force the veins to pop out. Okay, so suppose if you don't have a tourniquet, what you can do is you can use a sphygmomanometer. Tie the sphygmomanometer to the arm of the patient, inflate it to just below the diastolic blood pressure, that is 50 to 60 mmHg, and that will prevent the venous backflow. If you don't have tourniquet or sphygmomanometer, what you can do is you can use a handkerchief as a tourniquet. Once you have tied the tourniquet at the patient's arm, ask the patient to hang his arm and then ask the patient to clench and relax his fist. So what it does is, you can see the veins are not very evident here in the patient's arm. So when the patient starts clenching and relaxing his fist, what happens is the vein starts popping out. You can see the veins clearly visible. So this vein will be a good candidate for placing a IV cannula. Then last thing is you can tap gently over the vein using your 3 finger like this. So what it does is it causes the inflammation in that area. When there is inflammation, there is vasodilation of the blood vessels. Hence there will be increased blood in that region and increase in size of the vein. So that will make the vein pop. Then we come to the grip, how we grip the cannula while inserting it inside the vein. There are multiple grips. I'll show you. One is where we keep our fingers at the wings of the cannula and our thumb at the locking cap. So this prevents the stylet to being pushed back and we force it inside the vein. Second grip is we keep our fingers, these fingers at the injection port. Even this is acceptable. Now you can see both these grips, they have the thumb at the injection port. This prevents the stylet to be pushed back. Why do we not want the stylet to be pushed back? Because it acts as a guide, it acts as the entry point, it creates an entry point for the IV cannula. IV cannula alone cannot go inside the vein, it needs something else to puncture a hole in the skin and the vein, and then it can be inserted in. So this stylet helps in puncturing that hole in the skin and the vein and acts as a support to insert it inside the vein. Then another grip that can be used is you place your finger at the wings or at the injection port and your thumb at this stylet grip. This is also fine. I'll show you a video where I've used the grip where the thumb is at the locking cap and the thumb is at the injection port. Look at the difference between the two. So here you can see I'll be pushing the IV cannula against wall of my keyboard. You can see the stylet will not be pushed back because I have supported it from the locking cap region. Look at this. I'm pushing it against the wall, it is not being pushed back. Okay. Whereas now you can see my grip is my thumb and my fingers both are at the injection port. It is the thumb is not supporting the stylet. So what happens is when I push the IV cannula against the wall of the keyboard, you can see this stylet is being pushed back. Again, you can see the stylet is here. So when I push it against the wall of the keyboard, you can see the stylet is pushed back and the flexible cannula is not able to penetrate inside the skin and the vein. So always remember to support the cannula at the locking cap region or the stylet grip region. Then we have the bevel. Now as I've mentioned earlier, the bevel is the cut portion of the stylet tip. So this is the cut portion of the stylet, that is called as bevel. Now you have to keep this bevel always away from the skin. So this flat surface should be in contact with the skin, whereas this should be facing upwards. So I'll be showing you the video of both bevel down and bevel up. Let us start with the bevel down first. Now you can see the bevel is towards the skin. So when it comes in contact with the skin, it pushes the skin downwards. It doesn't puncture the skin instantaneously. So it is pushing the skin down, and the pain sensation the patient feels is for a longer duration. You can see the skin is being pushed downward and then the stylet is entering the skin and the vein. Okay, so the pain sensation is for a longer duration. Then we have the bevel up. In this you can see the bevel is facing away from the skin and it easily enters the vein without any discomfort to the patient. Of course there will be some minor discomfort to the patient, but as compared to the bevel down, bevel up is far more comfortable. Now we come to all the steps in placing cannula. We've already talked about inflating the vein using the tourniquet. If you don't have a tourniquet, you can use a sphygmomanometer or a handkerchief. Another step that you can do to inflate the vein is hanging the arm down, asking them to clench and release the fist, and tapping over the vein, lightly tapping over the vein. Now once you have inflated the vein, you can see the vein is inflated here. You're going to clean the surgical site. You're going to clean the site with the surgical spirit to disinfect the area. Then you insert the cannula. Now while inserting the cannula, I've already told you that we keep the bevel away from the skin, and once we enter the cannula inside the vein, we get 2 flashbacks. We'll see that here. Okay. Another thing I forgot to tell you that many of the times we have to palpate the vein. In this case the vein is clearly visible, so even if we don't palpate the vein, that is fine. But in some cases you can feel the vein but you are not able to see the vein, especially in dark patients. So in such cases you'll have to palpate the vein and determine the path of the vein and then insert the cannula. So this is what the doctor is doing here, palpating the vein. So the doctor is palpating the vein. He has decided that he'll place the IV cannula at this site, and the IV cannula will be inside this vein. Okay, So he has disinfected the area with the surgical spirit. Now he has held the cannula with that fingers over the wing region and thumb over the uh, locking cap region. Now another thing that you have to do is you have to pull back the skin to stabilize the vein and stabilize the skin. Okay, once you've made the skin taut, the needle is able to insert the skin easily. Now you can see that the doctor has pulled, that the nurse has pulled the skin back, and then he is inserting the needle. And you can see the stylet is being using the injection port to check for the patency of the IV cannula. Now you're going to push in 10 ml of normal saline. Okay, if the cannula is out of the vein, it is not inside the vein, and if you push the normal saline, what happens is the normal saline is deposited in the subcutaneous layer of the skin. So the patient will experience pain because there's a solution being deposited suddenly in the subcutaneous region. So because of the pressure, the patient will feel some pain and there will be swelling seen clearly. Okay, clearly evident swelling will be seen. Whereas if the cannula is inside the vein, you will not see any swelling because it is directly added to the blood and it is being redistributed throughout the body. So the patient will not feel any pain if the IV cannula is inside the vein, and there won't be any swelling. Whereas if the IV cannula is outside the vein, the patient will feel pain and the swelling will be seen clearly at the site of IV cannula placement. You can see the solution being pushed in and the patient doesn't feel any pain, no swelling is seen. So this is a good sign that you are inside the IV cannula. Now you are going to fix the, I'll fast forward, you're going to use the wings to fix the cannula to the skin. So this is how you place a IV cannula. Here they are checking it again. Maybe while fixing the cannula it might be pushed out of the vein, so they are checking the patency again. So that's how you place a IV cannula. Another thing I would like to tell you is that how to keep the cannula fixed before the fixation with a surgical tape. Now you can see the doctor, the nursing staff, he is keeping his finger over one of the wing and one finger at the vein at the tip here. Okay, what he is doing here is that he's applying pressure over the vein so as to prevent the blood coming out of the cannula. If you have applied pressure over the vein, there won't be any blood going back. And using the index finger over the wing, what he is doing is he is fixing the cannula in position while placing the locking cap. So you can see the full length of the cannula. So what I have done is I have placed the finger at the end of where the cannula length ends. I kept two fingers over there. This is what I prefer. I don't place my fingers at the cannula. I place my finger at the end of the cannula. And in the previous video, the doctor placed his fingers at the wing region. Now you can see the two fingers placed at the end of the cannula, applying pressure over the vein, and the doctor in the previous video, index finger was placed over the wing to keep it in proper position. Now what I prefer is I don't apply pressure over the wing region, I apply pressure over the injection port. That is a far better method because it firmly fixes all of the cannula over the skin. It doesn't move at all. So in my experience, it is far more secure. So that's it.
That's all,
how to place a IV cannula. I hope you guys learned from this small video. As you guys all know that we are at war with a pandemic, COVID-19 pandemic. So what you can do to help in fighting the coronavirus pandemic: wash your hands regularly, avoid unnecessary traveling, wear mask whenever possible, whenever you're outside, and if somebody is sick at home or you are sick, always wear a mask even at home. Keep a physical distance. I don't prefer a term social distance. I prefer a term physical distancing. We are still in contact with people on social media. We are still socially active. We are not socially distancing. We are physically distancing. At least a distance of 6 feet when you are outside your home with other people. Thank you everyone.